Welcome to the Antimicrobial Stewardship Project webinar series. I'm Dr. Marnie Peterson, the Outreach Coordinator for the project, which was created by the Center for Infectious Disease Research and Policy at the University of Minnesota. Today, we are pleased to have Dr. Rachel Smith as our speaker today for her webinar titled, as you can see there on your screen, The Core Elements of Human Antibiotic Stewardship Programs in Resource-Limited Settings. And I just wanted to bring to your attention that this topic was also a featured publication from the Centers for Disease Control and Prevention. A little bit of background about Dr. Smith. She's a medical epidemiologist that joined the U.S. Centers for Disease Control and Prevention in 2011 as an epidemic intelligence officer in the Division of Foodborne, Waterborne, and Environmental Diseases. In 2015, she joined the Division of Healthcare Quality Promotion, where she leads a team within the International Infection Control Program focusing on healthcare-associated infection surveillance and control of antimicrobial resistance in low and middle-income countries. Dr. Smith studied at the University of California, Berkeley, and graduated summa cum laude with a BA in English Literature. She then received her medical degree from the University of California, San Francisco, where she also completed her internal medicine residency. She then received a master's in public health from the University of California, Berkeley, in maternal and child health. So with that, I'd like to also mention to our participants today that at any time during our webinar, we encourage you to submit questions and engage with our speaker, and you can do so by writing those questions or comments in the WebEx chat box located at the bottom right corner of your screen. Make sure to send your questions to all panelists, and these will be reviewed at the end of the webinar. And just be aware that all of your lines are muted, so this is the way that you will engage with the speaker. And our webinar today is also being recorded such that you can share this webinar with your colleagues or go back and re-review it. So with that, I'd like to welcome Dr. Smith to our webinar series today, and we look forward to your presentation.
Great, thank you, Marnie. So today I'm going to be talking about our CDC publication that came out recently, The Core Elements of Human Antibiotic Stewardship Programs in Resource-Limited Settings. Thank you to the CIDRAP team for having me for this webinar, and I'm looking forward to an interesting conversation. So I'm going to start with some learning objectives for this webinar. By the end of my presentation, folks who are listening should be able to better understand the challenges that are faced by governments and facilities in resource-limited settings in setting up antimicrobial stewardship programs. You should be able to name two of the proposed strategies for implementing stewardship programs at the national level in resource-limited settings, and also gain a better understanding about how to use capacity levels to guide the choice of antibiotic stewardship activities in acute care hospitals in resource-limited settings. So hopefully we'll have fulfilled these by the end of our webinar. So I'm going to start talking a little bit about antimicrobial resistance, which, as I think most folks know, is a growing problem globally. The rates of antimicrobial resistance, or AR, have been increasing worldwide, especially in resource-limited settings, which is where our group mostly works. And in some places where we work, over 60 to 80% of Enterobacteriaceae are resistant to carbapenems, which is concerning because that's one of the last lines of treatment for these types of infections. And although this is a problem primarily in the resource-limited settings, the low and middle income countries in which we work, we know that antibiotic resistance doesn't stay within a single country's borders. And any resistance has the potential to affect us in the United States, especially with global travel and medical tourism. And we already see that in our work here at CDC, where we see folks who are back in the United States or travel to the United States and end up with infections that show resistance patterns that are commonly found elsewhere, but not commonly found in the United States. And getting to the drivers of resistance in resource-limited settings, there are some that are fairly similar to the drivers of resistance in the US. So inappropriate antibiotic prescribing practices, which we're going to talk a little bit about, we're going to talk about today, are problems in resource-limited settings as well as in the United States. But then they have other drivers that maybe are less relevant to antibiotic resistance drivers in the US. So these would be things like poor sanitation infrastructure. We certainly visit hospitals where we see more than one person in a bed, where there's one cleaner for 900 beds in a hospital. And so those certainly can help with, or that can be some of the drivers of resistance. And then poor diagnostic stewardship. And this is generally where, labs in some of these facilities in these countries are not well capacitated or, thought to give faulty results. And so folks, clinicians in facilities don't use cultures or don't use diagnostic tests to help guide their choices of antibiotics the way we might in the United States. And that can certainly lead to resistance by using broad antibiotics and then not narrowing with culture data to guide you. So how can antibiotic stewardship programs help? And this may be sort of a review for many people on the line who are familiar with these types of programs, but stewardship programs, which are coordinated interventions designed to improve and measure the appropriate use of antibiotics, can definitely help with some of these issues. They actually have multifold goals. They help, antibiotic stewardship programs help clinicians improve patient care. They can improve patient safety through increased infection cure rates and increase the frequency of correct prescribing for therapy and for prophylaxis. But it's this last icon where we understand that stewardship programs can assist or help with reducing rates of antibiotic resistance that makes it such an attractive program for combating the globally rising rates of AR that we see in low and middle income countries. So what do we know about antibiotic use in resource-limited settings? In a nutshell, the answer is not very much. There's very little systematic data that's being collected in most of the countries where we work that would be classified as low and middle income countries. There's certainly occasionally, reports in the literature that might be from a single center or a point prevalence survey that's done in one hospital in a country and published. So we might know a little bit about how antibiotics are used in that one place, but we don't understand a lot about how antibiotic use is how antibiotics are being used sort of writ large across these countries. The WHO, or World Health Organization, actually released a report on antimicrobial consumption this week in coordination with the World Antibiotic Awareness Week that reported on antibiotic consumption in countries around the world. And really, there was very minimal data from low and middle income countries. If you look at the map on the left here, you can see that this is the map that shows which countries provided data that were included in the WHO report, and those countries are shaded in a green color. And so you can see there's vast swaths of gray across Africa and Southeast Asia and East Asia, where countries did not provide any data, and so they're sort of a black box in terms of how antibiotic consumption is going on in those countries, at least in terms of this report. And the second take home from this WHO report, I think, is that the rates of use really varied widely when there were reported rates. And so on the right, I've included a couple of the rates that were reported in the WHO report. The rates are in DDDs per 1,000 people per day, which is their preferred rate. And you can see that both the high and the low rate of antibiotic consumption occurred in what we would consider low and middle income countries. So Mongolia had the highest rate of antibiotic consumption at 64 DDDs per 1,000 people per day. And then a place in sub-Saharan Africa, Burundi, had the lowest rate at almost 4.5 DDDs per 1,000 people per day. And to give you a little bit of an anchor to sort of where those compare to countries that might be more like the United States, so some of the Western European countries, I've included the rates for the UK and Sweden, which are more in the sort of teens and 20s. And throughout this report, which I encourage everyone to look at if you're interested in this topic, most of the low and middle income countries that were included and did have rates reported were substantially higher than the UK and Sweden. So we know that there is overuse going on most likely, but obviously these types of reports don't tell us a lot about sort of any misuse or what kind of overuse is happening and how antibiotics are being used. And it also suggests, I think, and it's important to keep in mind as we think about this, that there may be underuse or lack of access in places, especially a country like Burundi that has a very low sort of DDD consumption rate. So I'm going to move on to talking about the challenges to implementing stewardship programs in some of our resource-limited settings. And so some of these may sound familiar to folks who work in this area in the United States, and some may be a little bit different. So we know that countries and facilities in resource-limited settings have lack of available and appropriate policies and guidelines. So both at the facility level and at a larger national level, these types of guidance documents often don't exist, or they're pulled from high-income countries and aren't really as relevant as they could be to the realities on the ground. Our resource-limited settings often lack the specific training programs that we think of when we think of stewardship programs. So these would be infectious disease and pharmacy training programs. And so these sort of specialty staff cadres don't exist, and the pipeline doesn't exist for them. There's often limited diagnostic and laboratory capacity. So as I said earlier, there's sort of a disconnect between diagnostic capacity and using that type of information to guide antibiotic choices, and then labs in general are very rudimentary in some of these places and don't even have the basic capacity to do antibiotic susceptibility testing. There's gaps in the ability to track and report relevant antibiotic use data. I mean, that's, I think, pretty clear, shown on the previous slide with the WHO's data. There's also scarce human and material resources. And then I think we often see that, a lot of these countries and governments and facilities have a lot of competing priorities. And so it's difficult sometimes to obtain support or buy-in for these activities when it's one of many sort of activities and things that needs to happen, and there's lots of public health work to do. So stewardship can get lost in the mess of things to do, for lack of a better term. So in our working country, we had realized that despite these challenges, there were a lot of ministries of health and facilities that were interested in thinking about how to start an antibiotic stewardship program, either nationally or at a facility level. And so our group was curious to find out what sort of guidance was available for implementing stewardship in resource-limited settings. Obviously, they have specific challenges that they face, and so we thought that guidance that was specifically directed at them would be needed. And so we looked at what was available, and it probably won't surprise folks to know that there wasn't much that was directed at these very specific settings. Existing stewardship guidance that was really designed for high-income countries and well-functioning healthcare systems. So I've included a picture on the right of the CDC's core elements in hospital antibiotic stewardship programs, the original document. And obviously this is a great document that has a wealth of information in it, but it really doesn't address the challenges that resource-limited settings face that I described on the last slide. And although I think most of us would agree that the core elements really outline some fundamental concepts in antibiotic stewardship programs that presumably could be reviewed and modified for the realities in a lower middle income country, we really struggled with the fact that there's really often very little in-country expertise in stewardship. And so it's difficult for folks at the ministry level or at a facility level to take a document like the original US focused core elements and modify it to fit their needs. They just don't often have the expertise needed to sort of figure out how to do that. And so it became clear pretty fast when we looked through the guidance that was out there that this was going to be a gap. And if we were going to have something for the countries where we work, we would need to probably put something together to guide their interest in implementing stewardship programs. So that brings us to the main focus of my talk today, which is this document, the core elements of antibiotic stewardship programs in resource-limited settings. And it's something that we put together over the course of the last year and recently published, and really tries to fill that gap that I just went over. The objectives of the document are to provide guidance for implementing stewardship programs in resource-limited settings, and that really uses the CDC core elements approach, and obviously is part of the core elements suite of materials. And within this document, there is intended language for several different audiences. So we have some national level strategies that are designed to speak to governments, ministers, subnational leadership. And then we also have some facility level strategies that are designed for acute care facilities and folks at an acute care facility who might start a stewardship program. And one of the things that we tried to do in this document is to try and align the creation and implementation of a stewardship program with other national and international public health programs. So what we don't want is for stewardship to be yet one more sort of siloed program that doesn't speak to the other sort of programs that are happening at a facility level, for instance. So if you have, a facility level program that's seeking to, promote the prevention of sepsis, which obviously has to do with antibiotics, we don't want in one breath to be saying give out antibiotics and treat sepsis rapidly, and in the next breath be saying don't give out antibiotics, follow the stewardship program. So we want this implementation of stewardship to talk to and be aligned with as much as possible other programs that are going on at facilities and at national governments, so that they are not in conflict with each other. It's worth mentioning there are gaps in this document, things that we didn't address. The document only addresses human health, so there's nothing in here about animal stewardship or environmental stewardship or environmental antibiotic use. And the document doesn't address stewardship for outpatient facilities or standalone pharmacies, both of which are definitely issues and have need for stewardship guidance in resource limited settings, but not covered in this particular document. So I'm going to talk a little bit about how the document was created over the past year. So we started off, as I alluded to earlier, with what we call an environmental scan of what was out there. So we looked through stewardship program materials and guidance documents, not just from the United States, but from many other countries. And all of them were, from high-income countries around the world. And then we did do a review of the literature to access some of these single studies and academic articles that reported on stewardship in resource limited settings to get a sense of what had been tried and what had been used and what was successful. We then spent a lot of time reviewing the technical materials from the CDC, including the 2014 Core Elements document. And we also were involved in some of the meetings and for the Core Elements implementation guide for small and critical access hospitals in the United States. So obviously some of the hospitals in the US that are relatively small and have the critical access designation have some of the similar challenges that hospitals in low and middle income countries have, although not all. And so we wanted to certainly make sure that whatever implementation guide was included in that document, we could review and make sure that if there had been some good ideas, that we incorporated those into this document. We also collaborated with our colleagues at the World Health Organization who have developed a working group that's also addressing some stewardship program materials and creating some documents. So we worked with them. And once we had a draft document that we thought was in a good place, we had it reviewed by several experts out in the field. So these included folks in academic institutions that do research on stewardship, some Ministry of Health staff that we work with in some of the countries where we work, as well as public health professionals that work in this stewardship area. And so really asked them to kind of give it a fresh look and a fresh set of eyes and tell us what they thought about it and whether they thought it was something that would be useful, feasible to do, and that would add to sort of the conversation that they were having around stewardship in low and middle income countries. So I'm going to spend the next bit of this talk talking about going through the national level framework that we developed as well as the facility level framework. So this busy table shows the tiered national level stewardship activities, and you can see that they're arranged by capacity or resource level from basic to intermediate to advanced. And the idea is that, starting a stewardship program either at a national level or at a facility level can be really overwhelming. There's a lot of things to do, and it's hard to know where to start, especially when the expertise in this area is very rudimentary. So we wanted to provide some examples of activities and tie them to different resource levels so that national stakeholders, ministries of health, governments could sort of identify where they are on the capacity level and then look to see what kind of activities we would expect them to be able to do relatively easily. So I'm going to go through these different capacity levels, talk a little bit more in depth about them. So at the basic level, this is where you have really very limited capacity, right? There's very limited resources. You might not have dedicated staff or many monetary resources, but there's still activities that you can do as a Ministry of Health or as a national stakeholder to start to grow your stewardship portfolio. And so these activities are both specifically, tailored to being able to be done with sort of basic resources, but they're also, designed to be the building blocks of, building a bigger and better stewardship program in the future. So these are things like promoting the creation of national committees, developing national or subnational stewardship action plans. So these are, basic building blocks of what you would need to do if you wanted to have a national antibiotic stewardship program. And then there's things like participating in antibiotic awareness campaigns and adopting policies regarding or requiring prescriptions before antibiotics can be given out. So those are things that, again, are good starting places and can be accomplished with relatively little resources. Moving on to the intermediate capacity level, this is a capacity level that requires some resources and planning and probably dedicated staff. So we're talking about activities that are, slightly more complicated than the basic level. And these are things like developing and securing access to recommended formularies, creating and promoting adherence to evidence-based treatment guidelines, promoting diagnostic stewardship, and supporting the inclusion of antibiotic stewardship training in pre-service curriculums or other standalone courses. So again, trying to build off of the basic activities to doing activities that require a little bit more resources and planning, but are not, particularly advanced, which we're going to get to next. So the advanced capacity includes activities that require really the establishment of a formal program with trained staff and dedicated resources. So these are activities that are certainly more complicated than the ones before that require a lot more time and effort and dedicated resources. So these are things like enforcing policies requiring prescriptions, tracking your antibiotic dispensing or measuring antibiotic use and assessing appropriateness, which as we know is difficult, describing resistance patterns, monitoring antibiotic quality, which is often a problem in some of our countries, and addressing the drivers of prescribing behavior. So you can see hopefully how the activities increase from sort of basic activities that are, require very little to more advanced activities that are things that in many cases we are working on in the United States ourselves. And these activities aren't meant to be exhaustive, certainly. Like there may be other activities that fall into the basic, intermediate, or advanced level, but they're really just designed in the document to give examples to countries about sort of the types of activities they might be able to do at a specific capacity or resource level. So I'm going to go through just a couple examples, some of which may be familiar to you all, but an example of the basic level activity was to participate in an antibiotic awareness campaign. So these would be things like engaging your stakeholders around the campaign messaging, figuring out what you're going to focus on. Certainly, you would think about timing it to coincide with national or international antibiotic awareness weeks, such as the week that we're in now. And then I think really one of the reasons why this fits into more of a basic level activity is because there's great materials and toolkits available from places like the World Health Organization and CDC that can really take a lot of the work and effort out of creating, the campaign from scratch. And so I've linked to some of those documents here. But I think we really see that ministries of health and other national stakeholders would be able to take those toolkits and really sort of run with the idea of participating in one of these antibiotic awareness campaigns and not have to build it up from the ground up by themselves. And then, of course, once the campaign is been organized, disseminating it through existing social media and communication channels. Many countries already have these existing channels that they're using for other public health campaigns. infections, be it around TB or malaria. And so hopefully those similar channels can be used to distribute messaging around antibiotic awareness. So that gives you a flavor of how we were thinking about some of the basic level activities. An example of an advanced level activity would be something like measuring antibiotic use, which we obviously know is a difficult task. Again, there is some freely available tools that are available to help countries do this type of work. I've screenshotted one of the protocols that's available from the World Health Organization on measuring antibiotic consumption data. But even though these types of protocols are available, there's still so many steps and so many resources that need to be leveraged in order to actually implement this type of really large data collection and surveillance. So, you know, a country would need to establish their team and figure out what are the objectives of this program. You know, are they going to measure all antibiotic use, or are they just going to measure specific antibiotics they're interested in? Is it going to be once, or are they going to repeat it and see change? So they need to agree on sort of the objectives of the program. Then they need to identify sources of data to be used. So are they going to use import data? Are they going to actually try and get at what's happening at the facility level in terms of consumption? And then once they figured out where the data comes from, they're going to try to engage stakeholders and the data providers in order to make sure that they have everybody on board to try and get the data. Then, of course, data collection itself with validation and analysis is a large lift. And then where we see often some of our colleagues get stuck is that once you've got all this data, you want to use it for some sort of action, and formulating a report or disseminating that to stakeholders can be a large lift as well in terms of trying to synthesize and interpret the data. So you can see, I hope, how, you know, some of these activities around measuring antibiotic use can be a lot more complicated and require a lot more resources than some of the more basic activities. So I'm going to move on to talking about the facility level framework. So this is the framework that's more for the, you know, an acute care facility trying to put together an antibiotic stewardship program and leaving the national level, ministry level facility, or the ministry level framework for now. So the main gist of the section on acute care facilities, I think, overall is that we really tried to make the case that all facilities can develop a stewardship program, really regardless of their resource level. We understand that having a laboratory, a functional laboratory, or a pharmacy on site is obviously helpful and can provide a lot of assistance to a stewardship program, but I hope that I'll be able to convince you that they're not required, and they often aren't available in facilities where we work. And so I think it's important to try and figure out how facilities can start with small, simple programs around stewardship and build towards a more complicated or complex program as resources and time allow. So again, trying to take the kind of you know, overwhelming task of starting a stewardship program and really break it down to sort of how to simply get started with something that can make a difference in terms of antibiotic use. So this part of the document starts with the foundational structures of a stewardship program in a facility, and none of this is going to be, you know, particularly different for those of you that are familiar with the core elements documents, but I think it's really the implementation that we felt like we needed to address for resource limited settings. So the first foundational structure of a stewardship program in resource limited settings is a single focal point with responsibility for the program, right? So if there's nobody who is responsible for the program, it's not going to get very far. The buck has to stop somewhere, and someone needs to be moving this program forward. In terms of the implementation, you know, it doesn't have to be an ID trained physician as it is in, you know, most tertiary care centers in the United States. There's actually some evidence to suggest that pharmacists can serve in this role if they're given appropriate education, and that came out of South Africa. But we do want to acknowledge, obviously, that physician involvement is probably going to be very valuable, just given the sort of hospital hierarchy that exists in many of these countries. So that's the first point. The second foundational structure is support from hospital leadership. So, right, if the hospital doesn't have buy-in and doesn't think this is an important and valuable program, then, that is going to be a problem. And when we say hospital leadership support, what we really mean is sort of commitment of time and resources for the focal point. So this can't just be one more set of responsibilities for the focal point without any additional pay or time. So they need to have some time carved out and some dedicated resources to be able to actually promote stewardship and create the stewardship program. Second, it is valuable for the hospital leadership to show their buy-in via public support. So this might be in circulars that are given out to the facility or in supporting different educational opportunities, but it needs to be clear that the hospital leadership supports this type of facility having a stewardship program. So once those foundational structures are in place, we describe a framework that is really a stepwise approach to building a stewardship program in resource-limited settings. And again, these all are steps that map to core elements that we know and use in the United States, but just sort of modified slightly and maybe in a little bit of a different order and with some different implementation guidance in the document. So first, no big surprise, form an antibiotic stewardship committee. So gather together folks that you know are going to be helpful to you and important for you to engage with in order to build your stewardship program. And obviously this needs to be a multidisciplinary group that touches on all the different staff categories that are going to be important around stewardship, from pharmacy, if you have one, to nurses, to hospital leadership and physicians. Etc. So getting the Antibiotic Stewardship Committee together. And then we really encourage facilities to start with a single priority area for their stewardship program. Often in these facilities, and probably in facilities in the US, there's all sorts of problems with antibiotics and antibiotic use. And if you ask 6 different physicians or clinicians, they'll give you 6 different answers as to what the major issues are. But and so that can be very overwhelming, especially when you're trying to start the beginning of a program. And so we try to make the case that you need to start small, choose a single priority area. And we also make the point that, we definitely have talked to facilities where they feel like they just can't start a stewardship program because they don't have perfect data about antibiotic use at their facility. So they don't know where to start. And so, of course, if data exists on stewardship, or if data exists on antibiotic use, misuse or appropriateness of use at a facility, then that should definitely be used to help guide where your priority area is going to be. But if it doesn't exist, which it often doesn't, then while you try to get some data that can be imperfect data, you should try and figure out what kind of priority area you can identify, even if it doesn't mean doing a large scale point prevalence survey about antibiotic use before you start doing anything. So trying to sort of make the case that you shouldn't let the perfect be the enemy of the good, and that your physicians and folks that are on your stewardship committee likely will have ideas about where antibiotic use could be improved, and that can be the start of your priority area that you choose to begin with. Next, we have ensuring the appropriate policies or guidelines are in place. So like I said earlier, there's often a lack of these types of guidelines or policies in our countries, or they are pulled from IDSA or other places in more resource rich areas, and so the guidelines may not be relevant at all for what kind of antibiotics are on the ground. And so this is an important place once you've identified your priority area, let's say it's surgical prophylaxis, that making sure that you have policies and guidelines that your clinicians know that they need to follow. So if these aren't in place, even just drafting up and developing these types of guidelines is a big step towards, having a stewardship program. And so we want facilities to see that even the drafting of guidelines to help, improve appropriate use is part of a stewardship program. So next would be educating staff and publicizing your stewardship campaign. So this would involve, let's say, again, we're doing surgical prophylaxis, making sure that you've reached out to the OR staff, the surgeons, through either grand rounds or in-services, to try and make sure that this stewardship campaign is clearly a part of the sort of hospital consciousness and that people are aware that it's going on. And then finally moving towards implementing what we're calling targeted stewardship activities. And this is another place where, we see that there is just such a huge number of stewardship activities out there in the literature that it can be overwhelming for places to sort of figure out sort of what kind of stewardship activities they should be implementing at their facility. Should they be implementing an educational strategy, or should they be implementing a more restrictive strategy that doesn't allow antibiotics? And there's a lot of data, as you guys likely know, out in the literature about which ones are better and more sustainable, and on and on. And I think it can be really paralyzing for places that don't have a lot of resources and don't have a lot of experience with these activities to try and choose one of those and figure out what might work at their facility. So again, similar to the national level, we tried to provide a chart that helps facilities, get an idea of what stewardship activities are really possible given what they might have at their facility. So this is the table that's in the document, and on the left-hand side you'll see the activities. So these are the usual types of stewardship activities that folks are probably familiar with. And then across the horizontal, the horizon, we have various capacities in terms of having a bacteriology laboratory, a dedicated pharmacy, and a centralized antibiotic list. And then we have, sort of yes, no, whether or not these different activities can be done, sort of whether these capacities exist at your facility. And so the idea is that facilities will be able to say, okay, I have this and that, what makes sense for me to be focusing on as an activity, to try and take some of the guesswork out of it. So I'm going to go through a couple examples with these stewardship activities to try and illustrate how this table could be used to help facilities choose some of their stewardship activities. So functional bacteriology laboratory is a laboratory that can perform antimicrobial susceptibility testing. It doesn't have to be a laboratory that's on site at the facility. It could be a send-out lab or a national reference lab if that's part of their responsibilities, but it has to be a laboratory that provides results with sufficient turnaround time to actually impact clinical care. So that's what that capacity level means. A dedicated pharmacy is a pharmacy that's required by the facility to participate in their stewardship activities. So this could include, for instance, what we would think of as, the single on-site pharmacy that's sort of part of the hospital system. But it could also be an off-site but participating pharmacy, or a pharmacy network that's participating in the facility's stewardship program. And we see that sometimes in some places. It doesn't include a situation that is very common that we see a lot, which is where patients or their caregivers get a prescription from a clinician, and then it's their responsibility to leave the hospital, go down the street to a pharmacy that's completely unaffiliated with the hospital, and purchase a drug and bring it back to the facility. So that pharmacy, isn't within the purview of the hospital and really isn't going to be participating in their stewardship program. And so that makes it obviously difficult to have any sort of, to compel them to participate in a stewardship program. And then finally, a centralized antibiotic list is basically exactly what it sounds like, but is our way of sort of identifying what might be one of the data sources at a facility that likely doesn't have electronic medical records or electronic order entry. Is there a logbook that sort of records at the pharmacy or elsewhere all the antibiotics that the facility is giving out, or on a ward, for instance, maybe they have a list of the antibiotics that patients are receiving. And so this is sort of one of those areas where this would be a centralized antibiotic list that would be able to provide data that could be used for a variety of antibiotic stewardship activities. So I'm going to go through, like the national level, a few examples of how we would use this facility level implementation approach. So let's say Hospital X has no functional bacteriology laboratory, but does have a dedicated pharmacy on site, but that pharmacy doesn't really keep a centralized antibiotic list. They just give out antibiotics and don't have any list of what they've given out, or whether or not they, or who's getting what in the facility, let's say. So if you go through our table and kind of cheat sheet about antibiotic stewardship activities, you can see that there are several activities that we feel like you can do, even if you just have, a pharmacy that you can sort of engage to be a part of your stewardship efforts. So let's say that the facility decides they want to work on antibiotic reminders. So they're going to try to empower a pharmacy or the pharmacist to provide reminders to clinicians or patients that are coming to get antibiotics from the pharmacy. Now, there are definitely implementation issues with sort of trying to empower pharmacists to tell a doctor, a reminder about antibiotics. But again, this table is just to try and take out some of the guesswork in terms of what activity might be most appropriate in along sort of different capacity levels. So you can see that there's lots of options that this pharmacy could do, that this hospital could do, despite having really only one of these capacities at their site. Similarly, let's say that there's a hospital Y that has a functional bacteriology laboratory, but doesn't really have any sort of pharmacy to speak of on site and doesn't have a centralized antibiotic list. So again, looking at our handy cheat sheet table, you can see that there are several activities that they might be able to do. They could engage with their lab around doing selective lab reporting so that the laboratory reports out, narrower spectrum antibiotics that are more appropriate choices for culture positive infections, rather than listing every single thing to carbapenems and colistin, to try to encourage the facility's clinicians to choose narrower spectrum antibiotics. So hopefully that kind of illustrates how this table in the document might be used. I do want to call attention to the first two items on this table, which are really activities that we think that any facility can do as part of a stewardship program. And these are training on the guidelines. So we talked about that a little bit, in that, if you don't have guidelines for some of these common clinical syndromes, that putting together guidelines is a stewardship activity. And then training on those guidelines is also a stewardship activity, and really should be done before you expect folks to follow those guidelines and be sort of evaluated on their ability to follow them. And then antibiotic rounds, if there is a point of contact at a facility that, wants to or can embed themselves in an area where antibiotic use is high, like an ICU or a burn unit, and really work with physicians and clinicians there to optimize antibiotic use, that's something that can be done really without many of these capacities. So I hope I've convinced you that there is something that facilities can do regardless of what of having, some of these infrastructures like a bacteriology laboratory or a dedicated pharmacy. So what about monitoring and evaluation? Obviously, tracking and reporting on antibiotic use is a fundamental aspect of stewardship in U.S. hospitals and is included in the core elements. But it's often really logistically difficult. It requires the longitudinal collection of data, it's resource intensive, and in countries and facilities where there are no electronic health records and really very little experience with systematic data collection, it becomes really hard to say that this has to be part of a stewardship program, because it's often just a really high barrier for these places. And so in our document, we've considered this type of monitoring and evaluation of the program as really an advanced activity in resource-limited settings. But we do include a lot of information about how this type of data can be really valuable and provide important information for stakeholders and show the value of a program, and encourage that as resources allow, that it should be planned as part of the growth of a program to do monitoring, evaluation, reporting, and tracking of antibiotic use. And then we do have a little bit in the document that talks about sort of starting with more process monitors, what's the change in prescriptions of carbapenems, for instance, before you start moving on to sort of impact monitoring, resistance going up or going down, which obviously is very complicated and takes a lot longer to demonstrate any sort of effect. So that's the orientation and introduction to this document, which I hope everyone will read and share with folks that you think might be interested in it and use it. The next steps for the document, we're continuing to share it and get feedback from other experts, and really looking to users and countries that we think this could be really useful for, and getting feedback about its usability, feasibility, and hopefully at some point the efficacy. we've talked about, how we can use this experience to consider future guidance on outpatient settings, which we know is a big problem. As it is in the US. And then one thing that I think could be really valuable for this type of work would be to collect some real world examples of countries and facilities where they've been able to use the precepts in this document to actually take those from concept to practice. And so that those could be sort of collated and provided to countries so they can see a little bit more fleshed out examples than sort of what I've provided here, and get a sense of how this document can be used by looking at examples. So this, obviously, the creation of this document was a huge effort at CDC and with our external reviewers. So I want to acknowledge and thank the folks at CDC who have been deeply involved in this project over the last year, as well as our external reviewers from academia and ministries of health and in other public health areas who spent a lot of time reviewing this document and providing their expert input to make it a stronger document that it is today. And I will thank everyone for their attention, and hopefully there'll be some questions or comments from the attendees.
Great, Rachel. Thank you so much for taking us through the document and all your terrific work in this area. We did have a couple questions from our panel, our participants, and for our speaker, and I encourage you to continue to submit those questions or comments now at the end of the webinar. One of the questions actually that came in, and I know you didn't discuss, the focus of this is not outpatient setting, but in your work on this, starting to think about how the antibiotics are so freely available over the counter in some of the lower to middle income countries. And was there any discussion about, is there any recommendations within the more acute care setting around stewardship and education for patients as they come from, outside the acute care setting to inside the acute care setting?
Yeah, I mean, I think that one of the reasons we started with the acute care setting is because even though in a lot of these countries antibiotics are available over the counter, there's obviously, for patients who are inpatients, a lot more regulation about who's getting what, in terms of, generally speaking, they're getting in general what the physicians are or the other clinicians are prescribing. And so the problem around sort of the over-the-counter antibiotic use is not quite as relevant as it would be in outpatient outpatient stewardship in these countries. And I don't think we have good answers to sort of the best ways to approach that from a stewardship perspective. And I think that's really one of the places that we've been spending a lot of time trying to think about how we can work to provide stewardship guidance that does take into account the realities in these countries, which is that, antibiotics are available over the counter. There's obviously various financial incentives for those types of, business models. So antibiotics are providing a livelihood for these kind of pharmacies that are giving them out. I did see at a recent conference a really interesting presentation from a researcher in Bangladesh who they did some experimenting with, working directly with those sort of standalone pharmacies that are providing antibiotics over the counter, and instead worked with them to try and figure out how they could, instead of giving out antibiotics, switch their business model over to giving out for people who had very clear sort of, what we would consider respiratory infections that don't require antibiotics, selling them packs of Tylenol and nasal rinse and sort of creating an alternative business model to antibiotics, which I thought was a really interesting idea in terms of trying to, not just say over-the-counter antibiotics are bad, but instead say, we understand this is a business, so how can we help you figure out how to make a business model that aligns with our stewardship goals as well?
Thank you, Rachel, for that response. A second question is in relation relative to the metrics that you track, the defined daily doses is done more globally versus some of the days of therapy on antibiotic use. Just wondering if there's other metrics that they should be tracking that they've found helpful.
Yeah, I mean, I think that the reality is in our work in most of these countries, they generally are inclined to follow the WHO's preferred metrics, which are DDDs as opposed to DOTs, which we use obviously in the United States. And obviously there's pros and cons to using either of those metrics. But I think in general, because the World Health Organization, is sort of the voice that a lot of these countries are looking to, put together their national plans around antibiotic resistance and national plans around, stewardship. We in general sort of acknowledge that DDDs are going to be sort of what they are looking to produce and report up to the WHO. So while there may be clear reasons why for us in the United States DOT makes sense, I think just given the sort of work the WHO has done on this, and most countries are interested in and would and have reasons that they will follow the WHO metrics. I think in the end, as I sort of mentioned around kind of the monitoring and evaluation, I think that, we've tried to focus not less on sort of, that gathering of data, especially, at facilities that want to start something, and more around kind of just starting to try and pick an area and do some of these activities. And if you can monitor and track DDDs or DOTs, whichever one you'd prefer to do, or whichever one is possible at your facility, we can support them either way. But I think that there's a lot, we often get sort of looped into conversations about trying to kind of collect the perfect data and making sure that that isn't something that's stopping facilities or countries from at least starting with some of the building blocks that they might be able to implement in order to start their stewardship program. And as they're doing that, kind of figuring out, okay, well, how am I going to get a sense of what consumption is like in my country or in my facility?
Another question that we have is related to, for the lower to middle income countries, there's some problem with implementation around, do we have the resources, both financial and the human capital? Do you and then I noticed that really you described the tiered approach. So relative to that, do you have some goals around this where you're trying to get keeping track of those that are at least implementing at the basic level, maybe moving to intermediate? Are there some like baseline, and then are you going to be tracking some metrics around this?
Yeah, that's a great question. I think that our goal is to try and engage with countries that would be interested in using this document and figuring out sort of, I think first, whether it is useful to them. But I do think that, as with the core elements in the United States, there's some nice accompanying materials that sort of, have a self-assessment and sort of understanding where you are and sort of where your implementation gaps might be. And so I think there's definitely additional documents that, might be able to be developed that build off of this framework to try and help countries or facilities understand where they are sort of in the capacity level, and sort of help guide them to a little bit more kind of holding their hand to sort of say, okay, you filled out this, assessment. We understand that this is where your capacity level is. Here are some of the things you might, you might be able to do. Because obviously this document is much more of a sort of overall framework, and I think giving more sort of practical tools for implementation is probably going to be useful. In terms of tracking, which of our countries are at the various levels, I think that would be certainly interesting, but I think we have a little bit of work to do to ensure that the document is sort of usable and feasible and something that that countries are able to use before we sort of think about sort of how to track it on a larger scale.
So just to follow on to that, how will you, do you have plans to track the feasibility or the utility of the document in some way?
Yeah, so we have some of our countries that, some countries that we work in that are starting to, countries in Kenya, for instance, where they gave some early input on the document and are hopefully going to take it and run with it as they sort of put together their national sort of strategy for antibiotic stewardship. And so we work closely with those in those countries with those efforts to try and understand sort of any feedback that we can get on the document and or the strategy, the framework. And then we've been slowly kind of sharing it as it was published a couple months ago to try and get it in more people's hands so we can get some more feedback on it.
Yeah, it just seems, to start back, I forget what slide it was, but at the beginning, slide 3 or 4, just where you were showing the defined daily doses of antibiotics, just to even get to some of that data to populate out. The global map you showed there would be
Yeah.
of value too as a starting point. Just to
Oh,
switch gear.
I-
Oh, go ahead.
I was just going to say one thing, which is that, those efforts that WHO has around kind of those bigger surveillance efforts around antibiotic use and consumption, we've also been working with them sort of, not in a completely separate vein, but sort of as, a sort of sister effort to try and get some of the, in some countries we work where they are specifically interested in doing larger scale data collection to try and help with that implementation as well. So I think it's all part of, the effort to promote the stewardship and kind of getting a better sense of antibiotic consumption. So we do have some countries where we work where we're helping them sort of implement this larger WHO protocol that is a fairly advanced activity, but that we can provide some technical assistance for them to kind of get that done.
Great. So very much working towards collaboration and a collaborative effort here. Just to switch gears a little bit, to talk a little bit more about the role and different healthcare providers and implementation. So something that is really different when you think about the US versus the initiatives that you've laid out is it doesn't have to be led by a physician or even an ID defined physician, but you highlighted the role of the pharmacist, and then also other healthcare providers, I assume, are of value here too, such as the nursing staff.
Yep.
Some of the studies that have been published have talked about that. So that's very much a different kind of a different approach in a way.
Yes. Yeah. And I think, some of the, the data that I was referring to that comes out of South Africa about these, pharmacists that were trained and given, sort of the authority to be the points of contact for the stewardship program that was done in a network of hospitals and obviously required, additional training and resources to, capacitate them. And then of course there's sort of, the questions about, how pharmacists interact with clinicians and sort of breaking down some of the hierarchies that exist in hospitals. But I think, it was a study, but it showed that it could be done and that you could use sort of these staff categories that maybe are not sort of what we think of in the US to really promote a program where you don't have the option of using sort of the categories that we might think of here. And I think there was also some really good implementation, thoughts on that from the small and critical access hospital guide in the United States. And I actually had the opportunity to sit with the representatives from the critical access hospitals that came to CDC, where they were talking about how they have implemented the core elements documents. This was before the implementation guide came out, and they were using, pharmacists and nurses to do all sorts of aspects of a stewardship program because, they certainly don't have an on-site ID physician, and they often don't have a pharmacist that might sit on site. So nurses were involved. There was a lot of telemedicine that was being used. So it was really great to see how folks were thinking outside the box to try and understand how they can use what they have to create a program that, can adhere to some of these core elements without trying to build up the same sort of infrastructure that we have at, a large kind of academic hospital, for instance.
Absolutely. It's a really good point because of the potential limited resources. I don't know if you could speak about this too, but it seems as the educational pieces have been developed, even some of the MOOCs that are available through the British Society Antimicrobial Chemotherapy organization, they've really also highlighted the fact that it's really there's such country differences around education, cultural differences as well. I just wonder if you could talk a little bit about that as you were developing this document.
Yeah, I mean, I think there's just been an explosion in the amount of sort of materials that are out there. And as you mentioned, a lot of these kind of, online courses, some of which are free, often though in English or in, other sort of like broadly spoken languages. So sometimes we do encounter some of that as an issue. But I think that has really encouraged us just in the fact that obviously when you're choosing, when you're working in a place where, you know, there's not a lot of capacity for this, and you're not working with sort of the usual staff categories that we think of that might be sort of trained up on stewardship just as part of their, you know, pre-service or fellowship training, you know, we do need to think about sort of how you can train and capacitate those folks to kind of promote stewardship if that becomes, you know, part of their job, or if they become the focal point. So I think, you know, we have not, you know, explored the idea of providing additional training as part of this, you know, core elements. But I think there's a lot out there, and it might be useful to sort of think about how you could pull all those kind of opportunities into a single place that might be useful for folks that are looking for educational opportunities to kind of have a one-stop place where they could go and see what's available, either free or for charge, as opposed to, you know, trying to sort of institute a curriculum, you know, that sits at the ministry for every single country. I mean, I think, you know, obviously that would be great, but it's not necessarily feasible in most places.
Right, that's a very good point. Well, in our last 30 seconds here, Rachel, I know you're very close to this topic. Just share with us any of your next steps or some of your thoughts for the future.
Yeah, I mean, I think that, you know, what's been really interesting about working on this project is that, you know, stewardship was something our group works on, HAI surveillance, as well as, you know, AMR control and prevention. And stewardship was something that we always knew we wanted to work on and we thought was important, but it was really, we were pushed by countries and by facilities that were demanding this and demanding and asking for, you know, help with this. And so I think it was really a great opportunity to sort of like see them lead the way and wanting this for their facilities and in their national structures. And so, you know, it's a privilege to work in places where this is what they want and we can provide something for them, and that it's not us sort of saying, oh, this is important, you should work on this, and just really having it be led by them, and being able to provide the technical assistance, which is obviously our skill set, to be able to help folks kind of do what they are interested in and motivated to do. So it's been a great experience.
Well, terrific. Well, thank you, Dr. Smith, very much. I'm going to close out the webinar today. Yeah, we're out of time, but just wanted to thank all our participants for joining us today. And just to remind everyone, the webinar was recorded, so please share it with your colleagues, your friends, or if you need to re-review it. And just thank Dr. Smith for her terrific work in sharing it with us today.
Thanks.